Positioning in long-term care is one of the areas that is of most importance to therapists and to other healthcare givers alike. The difference between poor wheelchair positioning and correct wheelchair positioning can make all the difference between creating musculoskeletal deformities, decreasing function, and causing even further problems for the patient as well as for the caregivers. One of the areas we'd like to look at are some of the problems that arise from improper positioning. Some of the problems we experience in long-term care are positions which promote musculoskeletal deformity. That could be due to a number of causes. It could be due to abnormal tone or habitual posturing without intervention, total flexion patterns, total extension patterns, or progressive disease that affects the musculoskeletal system. It could also be a function of the wheelchair design itself, which is something we'll take a look at a little bit later. Another problem is decreased function due to the inadequate structural support. Again, it could be the poor wheelchair design itself. It could be a problem of decreased proximal stability, or it could be a number of reasons that we'll cover also. Another problem we have is decreased independence due to inability to propel the wheelchair. Often that is because a resident has been placed in an appropriate wheelchair, either one that cannot be propelled by the resident or one that was not designed to be propelled at all. It may be also a problem to inappropriate truncal stability, hemiplegia, abnormal tone, or a number of other reasons. Another thing we see often in nursing homes is increased discomfort and pain, which can be aggravated by poor positioning. Ill-fitting chairs may impinge on the resident, it may cause pressure areas, or there may be areas of inadequate support which lead to improper body alignment and uneven distribution of weight. Another problem we find is increased incidence of decubitus ulcer or skin breakdown. Often that's a combination of tissue shearing, friction, and the time-pressure relationship. Also included in factors are things like moisture, temperature, poor nutrition, anemia, or hypoproteinemia. Another thing we look at is a problem from improper positioning is increased abnormal muscle tone. Quite often, proper positioning can either inhibit abnormal tone or can actually exacerbate abnormal tone patterns. It can cause them to be asymmetrical. It can cause them to assume really poor positioning that once habituated is difficult to correct. By providing external support to align the body symmetrically, the potential for deformity is often decreased. Decreased respiratory function or cardiac output is another problem with poor positioning. When the trunk is supported to allow increased diaphragmatic excursion, the effort necessary for the individual to breathe may decrease. This decrease demands on the heart, therefore increasing cardiac performance. One of the last things that is important to note is withdrawal or decreased stimulation from poor positioning. If a person's head is not aligned vertically and in midline, it is much more difficult for them to scan their environment and for other people to make contact with them. This could lead to further withdrawal or depression in some cases. This has been well documented in much of the literature. We'll now take a look at some slides that demonstrate different types of wheelchairs found in many facilities throughout the country. The basic wheelchair was...
No, I didn't give you an eye.
The basic wheelchair was not designed for geriatric populations. The basic wheelchair was designed for short-term mobility following fracture or surgery. Unfortunately, we depend on them in nursing homes for people's mobilities. And because we do, we need to use what we've got. In this first slide, this is a picture of a standard wheelchair you would find in most facilities. It's not in very good repair. The vinyl is torn in several places. There are no footrests. The seat is very hammocked already. Luckily, this one does have the desk arms. They are removable. When it does have the footrest on, these are the swing-away removable type. If you need to have a wheelchair, this is probably the best one that you can get in many facilities. typically what you'll find are fixed arms that are the full length and fixed footrests, which are also very difficult to adjust. Okay? This is one that can be adapted. And a little bit later I'll show you how I've taken some chairs like this and with some minor adaptations have made them appropriate for some residents. Okay? In the next slide, this is a standard, what they call convalescent chair. Again, it has the high back, non-removable, it's very difficult for transfers. It has a table which can be nice, except that because of the mechanism here, it's very difficult to put on with a resident in it. There's absolutely no lateral support. This dimension here is way too long for most patients. What ends up happening is they end up going into a posterior pelvic tilt to be able to clear with their knees. This also has, although this one is missing, it also has a one-piece retractable footrest. Again, which you cannot adjust up and down at all. So again, this is not a good chair, but in a pinch with some adaptations, it can be used in nursing homes. And I will show some examples later on of how I've taken a chair like this and adapted it for a patient. In the next slide, we have, it's a basic Jerry chair. I call it a molded Jerry chair. You may have seen them in your facilities, where they're basically molded out the seat in the back. Again, it does recline. It has the table. This footrest, again, does not provide adequate support. The only time that it actually moves is when you recline the patient. If you left the patient in this for a long time, you'd end up being at risk for having foot drop. The same thing with Jerry chairs holds true. In our next slide, which is a standard Jerry chair, every facility in the country must have one like this. Again, they're very popular. The bottom line is they are used as a restraint. It's difficult for a patient to get out of this chair, even with or without the table. There's no foot support. It's a very wide seat. Again, you have that problem with the posterior pelvic tilt. If someone already has extensor tone and they're in that posterior pelvic tilt, all it does is facilitate more of that tone. In the next slide, just another shot of the Jerry chair. Again, showing the extra wide depth here, which is not good for most patients, and the fact that this is way too long, difficult for transfers, and it's non-removable. Again, with some adaptations, with some patients, this may be used. And later on, I will show where I have taken a chair like this and adapted it for a patient. Okay. In the next slide, this is a typical patient we find in a nursing home. He's in one of these convalescent chairs. He's slumped over to one side. He's propped up with an assortment of pillows. He looks uncomfortable. His feet are not well supported. His trunk is not well aligned. And this is what we find when we walk into nursing homes. And this illustrates the importance of intervention for positioning. Okay? In the next section, I'm going to talk a little bit more about some practical considerations in selecting a wheelchair. Practical considerations to keep in mind when you're evaluating a patient for a wheelchair. One of the first things we want to look at is the tonal characteristics of the patient. We want to look at things for flexor tone, extensor tone, any kind of variable tone. You might want to look at if they're flaccid. You want to note the effects that gravity have on them when you change their positioning. You might want to look at positions that may be more stressful, which may increase abnormal tones, or you may look at positions that actually may inhibit some of the abnormal tone. You want to look at asymmetries. You want to think about symmetrical stabilization to help inhibit some of that asymmetry. You want to look at their orthopedic involvement. Often in nursing homes, you'll find people with severe kyphosis, scoliosis, lordosis, windswept legs. You may find things like bony prominences, decreased range of motion, or fixed contractures. You may find leg length discrepancies or a combination. Quite often you find combinations of all these in nursing homes. You want to look at their functional capabilities. Can they propel the wheelchair independently? Can they transfer? Can they follow directions? Can they weight shift? This will all determine the type of intervention that you are going to provide for the patient and the type of wheelchair you're going to select. It'll also determine the amount of involvement that you're going to have to spend with this patient getting him correctly positioned. You want to look at both their cognitive and their behavioral status. Again, can they understand directions? Can they shift weight? Can they transfer? Can they propel the chair? Are they going to be a behavioral problem? Are you going to need a special kind of a seat belt so that they cannot take it off? Are you going to need any kind of a lap tray so that they can perform self-feeding or any kind of other functional tasks? All these things you take into consideration when you're thinking about what you're going to provide for that patient. Another important thing you need to look at is their rehabilitation goals. Are they going to be discharged? If so, what kind of a facility? Are they going home? Are they staying in that same facility? Are they going within the facility to a lower level of care or a higher level of care? This will all impact the kind of chair that you provide for the patient. You'll need to know if they're going to need any type of special holders, any type of special trays. Will they need vinyl coverings? Will they need communication devices? All that will determine, again, what you're going to provide for the patient. Again, keep in mind potential for follow-through of the program. This is one of the more difficult problems we have in nursing homes. Not only do we have problems in getting the caregivers, the primary caregivers in the facility, we also have problems with the families getting to accept some of the adaptations we've made to chairs. Again, with proper and constant reinforcement of the concepts of positioning, you can overcome some of those problems. Okay? Again, you want to know what are your readily available seating resources. Do you have 20 Jerry chairs and do you have 40 standard chairs? Do you have gunnel chairs? Do you have any kind of special chairs that you need to think about for specific patients? Do you have semi-recliners that you may be able to, that you may need for a specific patient? Those kind of things, you need to kind of have an idea before you get started, because that's really what's going to determine what you end up putting a patient in. Again, funding sources. In the majority of nursing homes, there are lots of different kinds of wheelchairs. Unfortunately, if you need a special chair, finding somebody to pay for it is very, very difficult. This is something that's going to vary from state to state and from facility to facility. It's going to be an area where you'll need a lot of cooperation from the administrator and the social workers at your facility. Okay? The next thing we're going to take a little bit of a look at is we're going to look at correct postural alignment. Okay? This demonstrates a person sitting in a wheelchair. It shows the normal curves of the spine. It shows basically, if all things were going well, this is how we'd like people to be seated in their wheelchair. Okay, you have even weight distribution. You have that natural curve of the spine. Again, if you need to, you can add a towel roll or a lumbar support in there. Okay, there's a slight anterior tilt of the pelvis. The head is erect. There's equal weight distribution over the ischial tuberosities. Okay, one of the main things that we need to keep in mind is typically correct postural alignment begins with the pelvis. Okay, that's basically where you start. Okay, that's going to determine where the head ends up, where the shoulders head up, and where the legs end up also. Some of the things you can do to ensure proper postural alignment is keeping the pelvis as symmetrical as possible, equal weight bearing over both sides. Try and maintain the knees at equal elevation. Okay? You want to check a couple of things. Check that the thighs are well supported. The hips, knees, and ankles are flexed to 90 degrees if you can get them to 90 degrees. You want the knees and feet lined up with the axes of the hip joints. And you want the feet to rest flat on a support with the toes pointing straight ahead. Okay? And here's a picture of somebody who's not well aligned. This is faulty postural alignment. Okay? Again, we see much of this in nursing homes. The person is basically slumped down. You've got that posterior pelvic tilt. You have undue pressure on the ischial tuberosities. Again, you're going to have the knee is higher than the hips. This all leads to unequal pressure, and again, this puts this person at risk for breakdown. Okay, note the pressure points caused by the posterior tilt of the pelvis. The knees are higher than the hips, and the head is aligned forward, okay? This is what we see a lot of in nursing homes, okay? Now, clients who assume this position for long periods quite often end up with decreased range of motion in the hips and the lumbar region, sometimes severe structural spinal deformities, and impaired arm and leg function, okay? One thing we can do to help avoid these posterior pelvic tilt is should be able to slip 3 to 4 fingers between the posterior skin creases, okay, of the knee and the edge of the seat. Okay, that way you'll know that you're not that you don't have too much space or not enough space in between there. You want to ensure adequate seat depth. You want to get that pelvis all the way back in the chair. Okay, you want to avoid seats that are too long, because if they are too long, again, the patient's going to scoot forward to try and clear. And we see that an awful lot in nursing homes. Okay, that's probably one of the more common things that we do see in nursing homes. The next thing we're going to look at is we're going to look at how you take a standard wheelchair, look at the different parts, and if you need to take it apart to make adjustments, we're going to go through that step by step right now.
This is your typical wheelchair found in most facilities. Torn seats, footrest out of place. This chair I'm going to strip down to the frame, and then Jesse's going to rebuild this chair for you. All you need is 2 tools, Phillips head screwdriver or a vice grip. First, I'm going to take the back off of this chair, which is very simple. Sometimes, because these chairs are so old, it makes it harder to get these pieces out. That's one. And now to take the seat out, you just take these plugs on each side of the chair and pull them out. And this seat slips completely out of the chair. There you have your frame. Jesse?
Okay. As Wally demonstrated, this is a typical chair. What you find quite often is this is the typical condition of a seat. It's torn. It's very much hammocked, okay? Again, if you have a seat that's very hammocked like this, what happens to the patients is when they sit in it, they get this internal rotation at the hips. Again, over long term, that can cause you some hip problems, but it can also inhibit anybody that has any problems with increased tone here, making them adduct more at the hips. Okay, so that's one thing we want to try and avoid. What I would do if I needed to use this chair for a patient is I would replace both the back and the seat. Okay, make them look like new. Again, get rid of some of that hammocking. Okay, and pretend that this one is already replaced. Okay, we're going to pretend that this is a brand new seat. Okay, again, this is pretty typical for nursing homes. Okay, maybe I should put these back in first. Okay. What we'll do is we'll say that we've replaced both of them. You've got new vinyl. Vinyl is pretty easy to find. You can find it just about anywhere. Walmart, a fabric store. It's fairly inexpensive. Okay. We'll say, put this back on. I'll slide this back on just for demonstrating purposes. Walmart might have to help.
Now it goes in. This piece goes right in there.
Yep. So we'll assume that we've already replaced this as a brand new piece of vinyl. Okay. Even with brand new vinyl, you're still going to get some hammocking over time. You may even get some that's not quite as strong, so you're going to get that hammocking. What I've done quite often is fabricated what I call a zero elevation solid seat insert. And that's basically what this is. It's a piece of tempered hardboard, and it is filled with flame retardant material, whatever you happen to find, foam, any kind of thing that qualifies flame retardant. It's covered with a bottom piece of cardboard, okay? So you can get this kind of shape here. Once you place it in the chair, okay, it sits right at the same level as these bars here. And that gives a nice solid seat to sit on, okay? Again, what you're doing is you're providing a nice solid seat. You're getting more equal weight distribution, okay? And that's one of the important things on these wheelchairs. This is one thing that can be done for almost every resident in the facility, okay? Then what I do after that is I get some type of a cushion. This is a gel type cushion. Again, because this is zero elevation, there's less problem with raising the patient a little bit too high in the chair. Okay? After I get this on, okay, I would get hold of a seat belt. Okay. I would attach it. There's several different kinds. There's several that Velcro in the front, or there's a kind you can get that actually swing around back and Velcro. The important thing is you want to get this 45-degree angle of pull on both sides here. Okay? That's what's going to keep that pelvis back in the chair. Okay? So that's the angle of pull that you would want. Okay? Right like that. No matter what kind of a belt it is, either front or rear opening, you want that 45-degree angle to keep the pelvis back. The next thing I would do is I would adjust these again. What you want to make sure is you're trying to get equal weight distribution on the thighs here. So what you want to do is get these up so that you have patients as level as you can with their seating surface, okay? That's going to try and distribute the weight a little bit better, okay? For a lot of our residents, this is the most basic intervention that you can do, and it's also one of the most important. Sometimes just the solid seat insert, the cushion, the seat belt, and adjusting the footrest is all they need. I have a little bit later several ladies. This was the only intervention that was done, and the results were really dramatic. Okay. What we'll do next is we'll take a look at some slides of some wheelchairs that have been adapted, and also with some before and after pictures of some of the residents that I've worked with. Okay, this is a series of slides that's going to show some different adaptations to wheelchairs and also some before and after pictures. This I've done is I put the solid seat insert. Okay, this one was covered with contact paper to make it look a little bit nicer. It has a gel cushion on top of it. It has the seat belt that's fastened again at that 45-degree angle. There are grommets on either end of this seat belt, and it's just bolted into the very last screw of the wheelchair. Very simple installation. This piece here is used to block one of her knees that tends to go into severe flexion. What happens is her knee hits that block and it relaxes and it makes her rest flat on the footrest, okay? It's well padded. You can't see this in the slide too well, but it's basically a solid piece of hardboard that's padded and then covered with corduroy material, okay? This has worked very well for this patient. Prior to that, she'd keep one foot way under the wheelchair and was at risk for further contracture, okay? The next slide shows another chair that was adapted. This has a fairly severe wedge. Again, this is a homemade wedge made out of foam insulation. It's covered with duct tape, again, to make it fire retardant and waterproof. Because of the severe wedge, now this woman, you'll see her later, had a severe extensor tone at the hips. The only way to combat some of that tone was to try and get her into some flexion, okay? So she has, again, a seat belt, attaches at 45-degree angles. This one whips around the back because she would take it off otherwise. Again, because of the severe wedge, the existing footrests were not able to be used, and I need to build this. It's just a wooden frame that's padded, and it's measured so her feet rest exactly on it. In a later slide, you'll see her in this chair. In the next slide, it's just another picture of the same wheelchair, showing that this, again, was added onto the chair to make up for that extra depth. Okay, the next slide. This is a semi-reclining wheelchair that was fabricated for a lady who, like most of our residents, has very, very sensitive skin. Everything needed to be padded. She needed a pad for the back, a contoured headrest, the side rails, armrest needed to be padded, even the calves and the footrest needed to be padded. Again, it has the seat belt at a 45-degree angle. In the next picture, I believe, is another angle of it. It's going to focus just a bit. Okay. Thank you. Okay. Again, these were just covered and padded. Same thing with the calf protectors, and this has worked out real well for this resident. This resident prior to this was in a cherry chair for a long period of time, and had already lost lots of range at the hips and at the knees. Okay, so this helped to accommodate for that and to help prevent further contractures. Okay. Okay, this is one of those convalescent chairs. Again, in its unadapted state, provides very little support. What I did was, this is just a quarter-round piece of that same hardboard. It's very thin, but it's rigid. It's padded, and it is attached on either side of the chair. Again, you'll see a picture of the lady in this. It provides bilateral trunk support to keep her in an upright position. Okay? But her footrest needed to be adjusted. I just added a block of wood, and that's covered with vinyl. Okay, that gives her the adequate knee support. I'll show you pictures of her in a minute. The next slide is another picture of the chair showing the same adaptations. The next slide, okay, and this one's real hard to see. Okay, this was a chair for an MS patient that I worked with. What happened with her is that she had one of those halos, which did not provide enough support. What it made her do was hyperextended the neck, okay, and her head would still fall forward. She would go underneath the halo. So this was, you'll see a front view in a minute, just attached. These are actually just pieces of splinting material that will bolt to the back and slide back in. Again, it's removable for transfers. The next slide shows another picture of it. Okay, you can see a little bit better. This is a contoured headrest. Okay, it slides in and out for transfers. The next slide, again, shows a close-up view of these. I believe the next slide shows, okay, a better side view. Okay, it's reclined a little bit. She has gravity to help keep her head in. Her head is much more symmetrically aligned. Okay, she has much less problem keeping her head up in the chair. And again, it's much more comfortable because it gives her some extra room. Okay. The next slide. Okay. Here's one of our typical patients. Again, she's in a chair, just like the one we saw a few minutes ago. No footrests. She's tied with a posy. The posy is about waist high. She's starting to slide down in the chair. And the next slide is the side view of her. Okay. Here she is. She's almost sliding out of the chair. Okay, there's that curve again. She has that posterior pelvic tilt. Luckily here she can reach the floor, but if it weren't for this, she would slide out of the chair certainly. Okay, and if she sat like that for prolonged periods of time, she'd start to get some pressure sores. Okay, the next slide shows the intervention. Okay, again, the most simple intervention: the solid seat insert, a gel cushion, and a seat belt that crosses the pelvis at 45 degrees. Okay? The next slide shows her a little bit better. Okay? Well positioned, the knees, the ankles, and she's no longer sliding. Okay? And because the weight is distributed more evenly, she's less likely for breakdown. Okay? The next slide. Okay? This is the woman who I made that chair with the quarter rounds on. Again, feet are unsupported, they're dangling, she's listing over to one side, very asymmetrical. Okay, the next slide. Okay, again, same problems. Okay, it's not a comfortable position to be in. Okay, here she is in the adapted chair. Again, she has those quarter round trunk laterals, keeps her very symmetrical. This built up footrest gave her that foot support. Okay, next slide. Okay, here's another view of her. She looks a lot more comfortable. Okay, she's much better positioned. Next slide. Okay, another lady, same position. Okay, she's got the posy around her. She's almost sliding out of the chair. A lot of knee extension, at risk of falling. The next slide shows her from the side and from the front. Again, she looks like she's about to fall out of that chair. And in effect, in the past, before intervention, she had fallen out of the chair on many occasions. Either that or the posy actually slipped up, all the way up on the chest, which can also be dangerous. Okay, the intervention is the next slide. Okay, again, the most simple intervention. The solid seat insert, which is hard to see here, the gel cushion, and the seat belt at 45 degrees. Okay, next slide. Okay. She looks much more comfortable, she looks more alert, people respond better to her, and she's got a lot of favorable comments from her family. Okay, next slide. Okay. Very difficult patient. This one has a severe kyphosis, lots of flexor tone. Again, she's in a standard chair, nothing's removable. She has a posy tied midway up the chair, okay? Very difficult to feed. It takes two people to feed this lady, okay? She's at risk of falling out of the chair, okay? Let's take a look at the next slide, which shows her again, severe kyphosis, okay? Severe kyphosis. That just helps to make her look like a little ball, okay? Okay, next slide. Okay. This is her adaptive wheelchair. This is a convalescent chair. Again, heavily adapted. Okay. On the next couple of slides, you'll see a heavily padded back. Again, because she is so severely kyphotic, she needed something very, very padded to help accommodate for that kyphosis. Okay. Okay. It's heavily padded here. We have a headband. Okay, that's used only 5 minutes before each meal, gives her that proprioceptive input. After 5 minutes of using the headband to get her into some more extension, she's able to keep her head up with just a slight tap of the forehead. Okay. The other adaptations to the chair were a gel cushion, a seat belt at 45-degree angles. The tray table had some armrests that were padded to give her some more support. Okay. Next slide. I added 2 quarter-round cushions to give her a little more abduction. Again, you can see the attachment of the headrest. Okay. Next slide. Just another picture of the chair itself. This is a piece of wood that the headrest is mounted on. It slides right over the chair. Again, can be removed for transfers. Okay, slide right over the chair. It's velcroed on, and this is a padded headrest that we'll see in the next couple of slides. Okay, next slide. Okay, here's a close-up of the headrest. There you go. Okay, good. Okay, this is just a piece of pine board that fits right over the top of the convalescent chair. This is a headrest, padded headrest that just fits right in. Okay, next one. Okay, just another view of the same chair. Again, the padded armrest that needs to be extended to help give us some more support. Okay, that's the final chair there. Good. That's okay. Good. Okay. Here's a lady, this chair we looked at earlier. This woman had severe extensor tone. She had been sitting in a Jerry chair for many years, which just exacerbated the extensor tone. Okay, she did the wedge, and then I needed to build up the footrest for her. So far, over time, it's a little easier to get her into the chair, and she's getting a little bit more flexion at the hips. Okay, next slide is one more picture of her in her chair. Again, it was a vast improvement over what she was in before. Next slide. Okay. Okay, here's a lady in one of those convalescent chairs. Again, without any intervention, providing no support, she listed heavily over to the right. Okay. She needed a gel cushion. The back needed to be padded. Okay. But you cannot see clearly in this slide. These are trunk laterals that come out on either side. They're made out of a thermoplastic material and bolted right into the frame and covered with the same cloth material. Okay. Next picture. Just another shot of her in the chair. Again, it's kind of hard to see the trunk laterals, but they come out on both sides and give her the support that she wants. One more picture of her. Okay. This last slide is just to illustrate what we use in long-term care. Again, what I call low-tech positioning. Okay? We use a lot of duct tape, and I'll show you a little bit more about the uses of duct tape. We use that to cover a lot of things to make them flame retardant and moisture proof. We use a lot of foam. This is concrete foam, tempered hardboard, plywood, got some cardboard in the bag, fabric, contact paper, here's some vinyl, and the handy-dandy sewing machine. These are all heavily used in positioning. Again, because we don't have a whole lot of resources, we need to be very, very creative in how we produce these things. Okay? I just want to show you a little bit more on how you can use basic materials. Okay? This is that solid zero elevation solid seat insert. Again, this is a piece of tempered hardboard. Okay? It's cut to the dimensions of the seat. Okay? Then on the bottom, you get a piece of cardboard. Okay? And you attach that on one side. After it's attached, you fill in this part with whatever you have available. If you have rags, pieces of foam, whatever, to fill that in. Okay? Then you tape it all up, and you get this shape. Okay? When the person sits in the chair, it becomes a nice flat surface. Again, this costs very little to make, but it's one of the more important things you can use for these sling seats. Okay? One other thing I want to mention is in starting a positioning program. Again, one of the difficulties in starting a positioning program is educating the staff. Okay? Basically, you start with a facility-wide in-service. Okay? And you keep reinforcing the basic concepts of positioning. Every time you position a resident, you need to provide an in-service and reinforce and reinforce. Okay? What we use is we call a positioning notebook. It goes at the nurse's station. Okay? We also use something that we post bedside. It says positioning on it. It says what kind of chair they have, what kind of footrests, seat belt, cushion, or any other special adaptations. Okay? Usually what we do, then in the notebook itself, we may Xerox it, and we may include a photograph of a resident correctly positioned. Again, to reinforce all the things that are important in keeping that resident well positioned. Okay? Another part of this notebook, okay, is the second section that is a resource section. It has articles on positioning. It has a glossary of terms. And it gives you some more information on how to construct specific items for wheelchairs and how to set up a positioning program. Okay? Also part of this will be the actual evaluation tool that you will be using to evaluate a patient, as well as a screening tool. And that will all be provided as part of the packet. Okay? Are there any questions that I've forgotten?
I have a question about the lady with the halo.
The lady with the halo?
How did that affect her function and how long
Okay.
did you keep it on?
Okay, she wants to know about the lady with the halo. Again, this lady was severely demented. She basically had no function left. I mean, she could not move. Well, she moved randomly, non-purposeful. What it helped with was with feeding. It decreased her feeding time significantly. And because of the intervention with the Halo, it only took one person to feed her as opposed to two in the past. It used to take one person just to hold her head up because of that severe, severe flexor tone. Okay? Now, with the use of the Halo, after 5 minutes, she gets some proprioceptive input. Just a little tap keeps her up, and they report that it's much easier to feed her. So again, that's how it affected her function. It made it easier for her to eat. Okay. Any other questions that I may have forgotten? Okay? Okay, I think that's it then. Thank you.